Hi everyone, this is Michelle from Mexico. Thank you for hearing us and watching us on YouTube, on our YouTube channel. Today in this new episode on our segment, a look into global insights, we have the honored guest of Dr. Warren Dorlac. He is one of the members from the program's pre-hospital trauma life support, and he will talk about a little of these topics, and also he will introduce himself for our new students, our med students that are just listening right now. Doctor, we are honored to have you here in our podcast.
All right, well, great. Thank you for having me. And I look like I'm disappearing, but I'm actually here in real life. So I'm Warren Dorlac. I'm the trauma medical director for pre-hospital trauma life support, which is one of the sort of premier programs of NAEMT. We are here currently in Panama City at the Latin American conference, where we've kind of just got finished talking about the updates, which will be coming out very soon, in the newest 10th edition of PHTLS. I'm a trauma surgeon, and that means I am not a paramedic, and I don't do what you guys do every day. I work primarily in a hospital, but work very closely with EMS. I've also been a member and part of the Committee on Tactical Combat Casualty Care with the military. Retired with 26 years of service in the United States Air Force. In addition to that, I carry a couple other jobs, and one of those is I'm the vice chair for the Committee on Trauma with the American College of Surgeons. So that's my background.
Thank you so much, Doctor. And right now we want to discuss with you one of the topics that maybe our audience, because a lot of our audience are new med students or new EMT students, and we want to share with them what is the pre-hospital trauma life support program, please.
All right, so pre-hospital trauma life support is consistent of a large number of things, but we'll kind of hit on some of the big highlights. So we've got a textbook that's being revised, currently in the 10th edition. The first edition and early on was led by Dr. Norman McSwain from New Orleans, Louisiana in the United States. And he's really the founder of PHTLS and got us all started. So we have a textbook. Along with the textbook, there is a course, a pre-hospital trauma life support course. And again, that is also revised about every 4 years. And so that will be coming out in its 10th edition. We try to correlate the current edition with the newest edition of ATLS. This year was a little unusual, and that is ATLS is running behind due to the pandemic. So we've had we're going to have our textbook out before ATLS. So it's been a little bit of a coordination challenge, but something that both ATLS and the PHTLS committees were up for. So normally, again, we would come out after ATLS, but this year we're coming out just before ATLS.
Thank you so much, Doctor. And you talked us when you were presenting yourself about the tactical combat casualty care program, and that we know as the EMTs already working on the emergencies that this program is like one of the previous program before the PHTLS come out. So could you please tell us what is the difference or what the students can expect to have on the tactical combat program and the PHTLS program, please?
Yeah, so that's a great question, Michelle. I think there's a couple really big differences. And one of them is in tactical combat casualty care, what may be good on the streets in Panama City, which is where we're at today, may not necessarily be the best medicine to practice in a tactical situation where you may find yourself either in harm's way or care under fire. And so trying to distinguish those. So the tactical combat casualty care breaks out pre-hospital medical care, primarily used by the military, but pre-hospital medical care into three different phases. One of those phases is care under fire. The next phase is your tactical field care. And the third phase is your tactical evacuation phase. So the basics for care under fire is one is control of the scene, which in a tactical situation that may mean trying to win the combat. And so that becomes the primary focus, but also trying to prevent yourself, your patients from any particular additional injury. So in the care under fire phase, really the only thing that the medic should be concerned about is controlling exsanguinating hemorrhage. Other than that, we're not going to be practicing any airway control. You might be involved in moving your patient out of harm's way. If, for instance, you have an isolated gunshot wound to the lower extremity, it might require you to remind the casualty themselves how to put the tourniquet on. If they don't have a tourniquet, you might throw them your tourniquet. Again, the idea is to avoid having more casualties in this situation. And again, trying to keep as many bullets headed downrange to the target as possible so that you win the firefight. So that's tactical, the first phase of tactical field care, which is care under fire. The next phase is the tactical field care, not care under fire. And this is where hopefully the paramedic or the enfermero de combate they are in a situation that's a little bit more controlled, and they can then go through all the standard things that we typically try and teach, which again involves assessment of the scene, again looking for exsanguinating hemorrhage, and then after that maybe going through it's not exactly the same as in the civilian world. We use a march system, but kind of going through the airway, respirations, looking at things that involve the circulation, and then addressing some of the other things that pop up on the battlefield, such as hypothermia. So we kind of go through a very similar process to the ABCDs. Again, PHTLS now uses XABCD, X being exsanguinating hemorrhage, and that's something that essentially has come out of the military environment. And then the third phase is evacuation phase. And so that's probably a little bit similar to how you're actually handling your patient once they get into an ambulance or once they get into the back of a helicopter, where again, the resources may be a little bit different than the resources that the medic is carrying in their backpack.
Okay. Thank you so much. I know as all our audience, our public will be very thankful with you to share what is the difference and what they can expect, so they can have a better idea for to take that in program and to have the information to start preparing themselves about everything. Right now, doctor, we want to know what are the things that we should expect from the 10th edition of the PHTLS, and what are like the most important things for the program right now, please?
Yeah, good question. So we just got finished with about an hour-long presentation going over all the most recent updates in the 10th edition. And I guess starting from beginning to the end, we can kind of go through a number of the changes. The beginning of the chapter really kind of talks about the history of PHTLS. It then follows into a chapter that looks at some of the principles within ATLS and PHTLS that we all tend to follow. One of Dr. Norm McSwain's tenets was that we need to give our students the knowledge and the education and the training that they need to be able to make decisions on the fly. Not every experience or every casualty or every patient that you run across is going to fit into a perfect model. And so hopefully we are able to give the paramedic, enfermero de combate, the knowledge needed to be able to make good decisions in terms of the care of the patient. The rest of the book kind of proceeds in sort of a logical fashion. Again, also very similar to ATLS. Under the airway section, there are some big changes. One of those is for the military. The military is removing the eye gel in tactical combat casualty care as the preferred extraglottic airway. And this is primarily due to heat and some logistical issues that have occurred with the eye gel. Eye gel may still be fine for the environment that you're working in, but there's no longer a sort of a preferred extraglottic or supraglottic airway. The other things within airway is trying to define when it's important to use an advanced airway versus when to use a basic adjunct. So I guess the rule should always be do the easiest thing first and try and avoid getting into some complicated situations. So it may require the patient to be intubated and have an extra, an ET tube or an endotracheal tube placed, but that would not be your first choice. You're going to try all the usual adjuncts beforehand, such as positioning of the patient, maybe using a nasopharyngeal airway, maybe using an oral airway with bagging of the patient with something such as an ambu bag, and then proceeding on, if those are not working, onto another airway such as a supraglottic airway, or maybe requiring endotracheal intubation depending on your skill level. For the tactical combat casualty care setting, generalized, you could say that endotracheal intubation for the basic combat medic is not typically taught or trained, and they typically will rely on a surgical airway. There's a number of reasons for that. Some of those include that the most common injuries on the battlefield where an airway may be lost, maybe related to a penetrating injury to the face or the neck, where trying to get good suction, good lighting is rather difficult in the combat setting. And so having a definitive airway such as surgical cricothyroidotomy is going to be maybe the preferred method there. So that's some of the things from airway. In terms of traumatic brain injury, there's quite a bit of new changes within traumatic brain injury. So I guess starting from the top would be one, deciding whether your patient really needs to be intubated or not. And there is some discussion about that in the textbook. And again, if your patient can be bagged, and especially if you have a very relatively short transport time, then the best thing may be to avoid endotracheal intubation. There's been lots of discussion about that in the literature. In terms of some other things with traumatic brain injury, where we're trying to avoid secondary injuries. Secondary injuries are things such as hypoxia, hypotension, hyperthermia, hypercoagulable states, a number of different things that go along. So probably historically, the two most important things have been with hypotension, avoiding hypotension. Previously, we've called hypotension a blood pressure less than 90. The new textbook pushes this up to 110. So the goal now in pre-hospital trauma life support is to try and maintain at least a systolic blood pressure of 110 when you suspect a moderate or severe traumatic brain injury. Hypoxia, we know that hypoxia is bad. Some really good data that has come out of Arizona, in the state of Arizona, with a large observational study that has been ongoing since started, I believe, somewhere around 2007 or so. But looking at thousands of patients within the state of Arizona, one thing that they've determined is that maybe this blood pressure of 110 is actually not enough. So this is an observational study. There is not a randomized study that looks at blood pressure, but there's evidence to suggest that maybe the better outcomes are from patients with a higher blood pressure. When we talk about cerebral perfusion pressure and how do we get more blood flow to the brain, especially injured brain, having a blood pressure, systolic blood pressure closer to 130 makes a little bit more sense if we suspect that our patient has an elevated intracranial pressure. So those are some of the key things from the head trauma chapter. I guess some of the other things that came up today in a question was tranexamic acid. Should we be using tranexamic acid in a moderate or severe traumatic brain injury? I will say that the committee, the pre-hospital trauma committee, was relatively mixed on this. The tactical combat casualty care committee from the military, though, has made a decision to, if you have moderate to severe traumatic brain injury, to go ahead and use tranexamic acid. The PHTLS textbook currently suggests that if you have prolonged time to evacuation or prolonged field care in that setting, then tranexamic acid would also be acceptable. We don't define what a prolonged transport time is, though. So there's a couple examples with traumatic brain injury. Also in traumatic brain injury, consistent reinforcement, and this has been study after study that has shown that every episode of hypoxia is bad. Every episode of hypotension is bad. If you combine and you have both hypotension and hypoxia in the pre-hospital setting, then you're essentially doubling the mortality that you get by already having hypoxia or hypotension individually by themselves. So really want to avoid hypoxia, really want to avoid hypotension. The Arizona EPIC study reconfirmed this, again, also showing that with having both in place doubles that mortality. So those things are really, really bad. We really want to avoid those. When it comes to penetrating chest trauma, the textbook talks about the use of a chest seal. If you're using a homemade chest seal, then you would probably be securing on 3 sides, making sure that you don't occlude all 4 sides. This allows for escape should there be development of a tension pneumothorax. It really prevents, the idea is to prevent the development of a tension pneumothorax. So chest seal, making sure it's covered on 3 sides, not all 4 sides, so that you can evacuate air spontaneously from the chest. In the abdominal trauma, a couple sort of highlights that are in there. One is our management for hemorrhagic shock is discussed in this chapter as well as in the shock chapter. Both really push for the avoidance, and we see this in almost all the chapters now, avoidance of crystalloid resuscitation and the emphasis on a more hemostatic resuscitation. This could be a 1-to-1-to-1 resuscitation with red cells, plasma, and platelets. It might be a whole blood resuscitation or whatever other blood products that you have. But if you have a patient that goes into hemorrhagic shock, the goal is to resuscitate with blood products and not to be using crystalloid. One of the things that we know from crystalloid resuscitation, both for traumatic brain injury as well as for hemorrhagic shock, is that it will also increase your mortality. So every 250 cc's of crystalloid or every 500 cc's of crystalloid incrementally going up will increase your mortality. So again, trying to avoid crystalloid. Crystalloid's bad, really bad. Damages more brain and it leads to a higher mortality. So I think those are some of the critical things. When we talk about pelvic trauma, there some of the changes are the use of a pelvic binder And then we have in there the indications for who should be using that. This is something that's come out of the Tactical Combat Casualty Care Committee and is now within the PHTLS textbook. Other things for musculoskeletal are a little bit more discussion in that chapter on pelvic binders. We also talk about in spinal trauma, the avoidance of manipulation of the spine. A lot of discussion on who needs spinal immobilization. We still recommend spinal immobilization. We still recommend use of a C-collar when it is indicated. So a lot of discussion about when that is indicated. At our institution and in the textbook, we do talk about the Canadian C-spine guidelines for which has an age of greater than 65. So if you have an elderly patient, even for a ground level fall, they run a risk of having an unstable spine fracture despite being asymptomatic. So those patients really should have some kind of cervical spinal immobilization. In the spine chapter, there's also the removal, or at least we no longer talk about the use of a short board. And this is based on not having a lot of really good evidence to show that it actually makes any difference. We don't have good data to support it. So that actually has been taken out of the book. It's no longer talked about. Another thing that was taken out of the book, going back up to the airway section, was the removal of the cricothyroidotomy with a needle in the aguja. This has been removed, as also there wasn't a lot of good evidence to support it, especially in the adult population. It may not be very effective at all. Chapter, other things that are going to PHTLS, there's chapter on disasters, there's chapter on environmental issues such as cold, heat, lightning, drowning, quite a new bit of new things in the drowning section that we'd recommend people take a look at. Part of that is based on some guidelines that have come out of United Kingdom and looking at when we should continue with a rescue versus when it becomes a body recovery issue. Things that seem to be important are the age of the patient, the temperature of the water, and the duration of the immersion. In terms of lightning, one thing there is of interest there is that golfing may not be as dangerous as we thought it was, and laying on the beach actually may be more dangerous in terms of your exposure to lightning and sudden death from a lightning strike. Remind me, what else did we not hit on that we talked about today?
We thought, I think that we already covered everything. Okay. Because we already talked about the environmental issues and the well, maybe from the pediatric section we can talk about a little bit about what it's involved in this program.
Yeah, so pediatric trauma, the textbook, thanks for reminding me of that. So the pediatric trauma chapter has a few different things. One of, and same in the burn chapter, there's a discussion about some fluid resuscitation models, trying to make those a little bit more simplified. So there's in there's a new discussion on the United States Army Institute of Surgical Research guidelines, their rules of 10. And so there's a chapter that talks about that, and there is some discussion there about the pediatric patient. Other things about pediatrics is it really emphasizes how trauma is such an important component of mortality in the pediatric patient. And really all the way up to age about 44, trauma continues to be one of our #1 causes of mortality in the United States, especially. So we also have a little bit of discussion in terms of non-accidental trauma, which is, some people would call that child abuse. And so there is a discussion about that, and seems to be a relatively growing problem. The pediatric chapter also introduces the value of use of a tourniquet, and there is a consensus statement from the pediatric trauma group now on the role of a tourniquet for hemorrhage control in pediatric patients. And most of the currently manufactured tourniquets will work for a pediatric sized patient.
Okay. Thank you, Doctor. Could you please tell us right now, Doctor, what is the current importance of the PHTLS program in paramedic training?
Okay, so what is the importance of pre-hospital trauma life support? Well, it's the most important part of your training. I mean, it's trauma. But I think also when we look at lives saved and the years of productive life, because the population, the trauma population really affects all ages, but has particularly great loss of life or of your years of life of being productive for the younger population. So I think an emphasis on that is probably worth saying. You know, there's lots of things that harm our patients, but if trauma is our number one cause of death up to age 44, then it seems like we should be focusing a large amount of our education and training for trauma. I will say that since the advent of PHTLS, the education programs that have come about, there's been a great improvement in overall care in the pre-hospital setting for trauma patients. As a trauma surgeon, I get to operate on no patient unless you guys bring them in alive. So super important for us to be able to really do anything. Some work from the military and ongoing in the civilian world too, but it really shows that the majority of deaths that occur, let's say on the battlefield, the majority of those deaths that occur are non-preventable. However, those deaths that occur that are preventable, number one cause is hemorrhage control. So we still need to do a lot for hemorrhage control, for the management of hemorrhage control. And so this should be really one of the big focuses within any paramedic pre-hospital trauma life support. We've pushed this all the way down to the lay population with the Stop the Bleed program done by the American College of Surgeons, often taught around the world by many of you in terms of being paramedics and involved in that education process. So trying to control hemorrhage as early as possible really has become a big focus of a lot of what we do. And hopefully down the road, the resuscitation pre-hospital using blood products is the next big landmark area that we're going to make a big improvement and change for.
Okay, thank you, Dr. Dorlac. For last and for not least, we want you, if you can share an experience of how paramedics trained in PHTLS made a definitive impact on a patient's survival.
Well, Michelle, I think that is that's a good point. But again, you know, no patient survives unless they're brought in by our pre-hospital providers. So whether you're an EMT, whether you're an EMT paramedic, whether you're on a helicopter doing critical care transport, again, no patient arrives to us unless the system is working well. And for the military, that'd be the joint trauma system. In the civilian world, that's hopefully our local trauma system. But no patient's going to survive without the pre-hospital trauma life care. So it's really the focus really should be on you all. And again, if we look at the areas where we're more likely to save more lives, it tends to be in the pre-hospital setting. So area that we really need to focus much more on than what we have in the past.
Okay, Doctor. Well, We are so thankful with you to share this time and this opportunity to share all the information with our audience. And well, we only want to say to you thanks, and that you are welcome to participate in another episode if you want, whenever you want with us. Okay.
Great. All right. Well, thanks for having me, and hopefully, at least someone found this interesting, or we hopefully got a little bit of tidbit of information out there. Again, see bleeding, stop the bleeding. Transfer your patient to your local trauma center.
Thanks for hearing and watching us, and see you on the next episode. Thank you.
Right, hold on.
Yes.